So this is very important purely because it shows whether the patient can do themselves. And secondly, movement of the heel, whether the heel moves equally on both the sides, and also the arch forms back. This is very important part of the examination. Then we go second single leg toe stand. This is mainly for looking for flat feet. Anyone got a flat feet, we should do this examination mainly for to find out whether the flat feet is flexible flat feet or rigid flat feet, and also the arch formation. The arch forms, it's a flexible flat feet. Arch does not form, is a rigid flat feet.
Foot AP and lateral, most of the times we do standing X-ray. So in standing position, basically the patient would be, I have made a special radiolucent wooden frame for the patient to stand. So patient stands on the film or onto the frame, and then the machine can come at somewhere around that angle of 10 degrees so that they can be centered somewhere around the talonavicular region, and then you can get these good foot AP views. And similarly, lateral view in standing position is also demonstrated. So patient can either do a single heel stance, but so you can make certain frames in which the patient can actually be standing and the cassette is right in the center.
The function is to increase the arch height as the toe dorsiflexes, which is the windlass mechanism, which is when you extend the toes, the arch height increases, which is the windlass. It acts like a windlass. In addition, it also gives a arch support. It is the second most important structure that basically supports the medial longitudinal arch. At this point, I would like to bring your attention that there are two longitudinal arches, and then there are two arches which are transverse. So the longitudinal arch on the medial side is the medial longitudinal arch. The arch on the lateral side is the lateral longitudinal arch. In addition, there is the arch that is formed transversely. There are two transverse arches, which are the anterior transverse arch.
So I've already talked about the area of the tenderness. So again, the same thing. So if this is the fibula, ATFL, the tenderness would be somewhere around here, which is at the attachment of the ATFL or along the ligament in substance or into the talus. CFL, the patient would have tenderness in this aspect, in the lower aspect of the fibula, along the tip of the fibula. Anterolateral ankle joint is just, when you're talking about ATFL, it's actually a centimeter above the tip.
And is transferred to the tibialis posterior. And in addition, you do something called a calcaneal osteotomy, which is a lateral column lengthening. So that is done in addition, because the patient also has a talonavicular uncoverage. So based on what the issues are, you go ahead and do these procedures, right? So heel valgus, do an MDCO. Tibialis posterior, do an FDL transfer, do debridement of tibialis posterior. Spring ligament, reconstruct the spring ligament. Lateral side, there is a talonavicular uncoverage, do a lateral column lengthening. There is a fixed forefoot supination, go for a Cotton's osteotomy, like has been done in like this, right? So here, it is easy to differentiate between the first and the fifth metatarsal because the forefoot varus has been corrected. Talonavicular uncoverage has been restored because the patient has undergone a lateral column lengthening. And in addition, the calcaneum has been brought down because the tendoachelis has been, recession has been done, and there is a medial shift osteotomy or a medial calcaneal sliding osteotomy that has been